Good morning, everybody. Welcome. Good morning. My name's Dr. Ali Raja, and I'm the president of SAEM, which is very exciting. I'm here to welcome you to our second keynote address and second plenary session. Today, we're showcasing the latest advancements in emergency medicine education through both a special keynote address and the presentation of our top educational research abstracts here at SAEM24. I hope you're all excited as I am. To get us started, please welcome Dr. Ryan Pettigo, who is chair of the SAEM Awards Committee, to recognize the second half of this year's award winners. Dr. Pettigo?
Thank you, President. We have another outstanding group of colleagues to recognize today, and we will begin with our most prestigious National Education Award, the Hal Jane Excellence in Education Award. This award is presented for outstanding contributions to emergency medicine through the teaching of others and the improvement of teaching. This awardee is widely recognized as one of the most distinguished educators in emergency medicine, with a national reputation as a leader in palliative medicine education, is an unwavering and dynamic advocate for superior education, an exemplary role model, extraordinary mentor, and an outstanding educator. It is my honor to present this year's Hal Jane Excellence in Education Award to Dr. Karen Jubenik at Yale University School of Medicine. And the remainder of our awards will be announced consecutively. The Mentor Award goes to Dr. Rebecca Smith-Coggins at Stanford University. Congratulations. And next, the FOMED Education Excellence in Education Award goes to Dr. Brian Gilberti at NYU Langone Health. Congratulations. And there are 3 awards for the Early Educator Award, and they go to Dr. Ellen Duncan at NYU Langone Health. Congratulations. Dr. Abra Fant at the Northwestern University Feinberg School of Medicine. Congratulations. And Dr. Xiaoqi Tony Zhang at Thomas Jefferson University. Congratulations. And there are 2 fellow awards. The Fellow Award in Pediatric Emergency Medicine and EMS go to Dr. Imikawabang Miki Ibia at Boston Children's Hospital. Receiving the award on his behalf is Dr. Derek Monette. Congratulations. And Dr. David Young at Yale University Department of Emergency Medicine. Congratulations. The RAMS Leadership and Education Awards go to Mr. Cole Eddingolf at Trinity School of Medicine for the RAMS Leadership in Emergency Medicine Award. Congratulations. And Dr. John Martindale at Brown Emergency Medicine for the RAMS Excellence in Education Award. Congratulations. No, take the picture. All right. And the RAMS Excellence in Research Awards go to Dr. Mohammed Ali Shaito at the University of Toledo. Congratulations. And Dr. Marina Gaeta-Gazzola at the NYU Grossman School of Medicine. Congratulations. And lastly, the RAMS DI Resident Education Innovation Award goes to Dr. Tamara Wilson at the Baylor College of Medicine. Congratulations. And congratulations again to all of our awardees. Let's give them another final round of applause. And now we'll turn it over to Dr. Ryan LaFollette, the SAEM24 Program Committee Chair.
Good morning again, everybody. And welcome to the Education Keynote Address. It's my great pleasure to introduce you to our speaker, Dr. Holly Caretta-Weyer. Dr. Caretta-Weyer is currently the Associate Dean of Admissions and Director of Assessment at Stanford University School of Medicine. She's a member of the International Competency-Based Medical Education Collaborators, a group that seeks to further research on CBME around the world. Dr. Caretta-Weyer was recently elected as the inaugural chair of CBME Task Force for Emergency Medicine, and her work with the Royal College of Physicians and Surgeons of Canada led to recognize her as the International Medical Educator of the Year in 2022. Please join me in welcoming Dr. Caretta-Weyer to the stage.
Good morning, everyone. So good to see so many friendly faces. Thank you for coming out. We are going to talk about competency-based education today from the perspective of thinking about this for patients and for learners. And I want to start with a common understanding of what education ought to be. Education ought to be a continuum. It shouldn't be experienced the way that all of us experienced it, as kind of this discontinuous, chaotic phenomenon. This is a bridge, not too far from my house, should look pretty recognizable to all of you. This is a bridge on the exact same highway. You drive over them, the scenery looks a little different. You don't experience driving over the road any differently though, right? You're just driving from point A to point B. That's not how education feels. Same road, looks like this right now actually. For those of you familiar, the one washes out on a regular basis. This is a really, really common phenomenon in California. But this is how our learners experience education, and this is often how our patients subsequently experience care. They feel like they're falling through craters. It's this discontinuous, difficult phenomenon. You have to relearn or restart every phase of training. Program directors in the room probably know you inherit residents, and you have no idea where they've come from, what they know, what they don't know. You treat them kind of like these black boxes. We want this, right? We want education to feel like this smooth superhighway, and that's what competency-based education theoretically promises us. That you start on day one, and then to the day you hang it up, it's all about your growth and development, who you are as a physician, how you take care of patients, what those outcomes are, and how you can do your best to meet those outcomes. Simple as that. I'm gonna make it sound a lot less simple in a minute, but this is really what we're trying to achieve. So why listen to me? This is what keeps me up at night. I actually have dreams about this. Someone the other day asked me if I talked about competency-based education in my sleep. I might. I spend all of my research time doing this. I mean, we eat, sleep, and breathe this at Stanford. But more importantly, why should you care? And I'm going to give you the reason this keeps me up at night. Anywhere from 40 to 65% of program directors graduate someone every year they wouldn't trust to take care of their family. Think about that. Depending upon the source you look at, published in the literature, based on surveys, program directors graduate someone every year they wouldn't trust to take care of their family. I know that doesn't necessarily surprise anyone in this room, and that kind of hurts, right? That makes us feel like a little bit of a gut check. That's why you should care. So, these are my graduating residents. I want to be able to look each and every one of them in the eye and say, we did right by you. We made sure that you were able to go out and take care of the patients. We made sure you were able to meet all of the outcomes that you care about as a learner and that the patients care about when you take care of them. That's our responsibility to them. And that's what every chair, every medical director wants when they hire someone. They want them to be able to take care of the patients, to be a good citizen, to be competent. So let's start with just a baseline of kind of where we are. What is competency-based education? It's really what I kind of alluded to. It is really education focused on the needs of patients and populations, so the outcomes that patients care about, how learners actually attain those outcomes, and then the development of a physician across the continuum from point A to point B, and it should be seamless. I'm gonna break that down further, really because I thinking about competency-based education is like a cake. And like every good cake, it has ingredients. And competency-based education has 5 key ingredients. Without one of them, it's not competency-based education. As Paul Hollywood would say in Great British Bake Off, you have a soggy sponge, right? My husband recently made a cheesecake that had no sugar. That's not a cheesecake, that's a block of cheese. Similar premise. And yes, it tasted exactly how you think it would. So competency-based education has 5 core ingredients, and I think we only often think of 3 of them. And I would challenge us today to think about all 5, and I'm gonna go through all 5 and kind of here's the pragmatic how we do this, and then connect that to how we operationalize this. So first, you need competencies, right? You need a framework on which to scaffold. This can be things like milestones, EPAs, we're gonna talk a little bit about this. 2, you need developmental progression. Each and every single one of us, as a trainee, had a developmental progression. It might have looked like this, might have looked like this, might have looked a little like this. But each one of us grew and developed over time. We learned. And you have to grow and develop over time in order to meet those clearly articulated competencies. And having that roadmap really helps us think about how we discuss this idea of how we get to the endpoint. The other one people often think about, and what I often hear competency-based education boil down to, is assessment. Yes, programmatic assessment, incredibly important. It is multiple points of assessment across multiple contexts from multiple perspectives to create this picture of competence. I liken this to, if anybody here is an art fan, pointillism. Georges Seurat had the picture of the painting, or the painting of the picnic. all of the dots. And when you think about programmatic assessment, it's a bunch of dots, right? You think about all of the different points in order to create the picture of the dog, the umbrella, the picnic basket. And you need all of those dots to have a full painting. These are the three things people often think like, okay, competency-based education. I would challenge us to think about the other two, which are actually perhaps just as important, if not more so. And that is faculty functioning as coaches, helping our trainees grow and develop along their own individualized trajectory. Meaning, you have data from assessment that tells you there are things they need to work on. And you think to yourself, okay, how am I going to individualize their experience, tailored, authentic, work-based experiences, in order to help them meet those outcomes, to grow and develop, and how am I going to coach them along the way to do that? And we're going to get to how this all comes together. Okay, so first, let's talk about that framework. I think a lot of us think, okay, yes, we have milestones, a lot of times they're hard to deal with, et cetera, et cetera. I'm going to break this down a little bit more into things that are more pragmatic, that we work with every day. And a lot of people have heard the term entrustable professional activities, and I think your brain just goes, jargon, boop, turns off, right? I'm going to rebrand those for you today. Everyday physician activities. That is simply what an EPA is. It is something we watch our trainees do every single day, and we have done so since the dawn of time. This is not new. It's just simply taking the things that we actually see, and we can objectively say, how involved did I need to be? How do I help you grow and get better at doing this thing? And these are things that we see all the time. Obtain and interpret focused history using data from all necessary sources. Create and prioritize a differential diagnosis. Manage clinical or diagnostic uncertainty. Perform the diagnostic and therapeutic procedures of an emergency physician. Interpret or implement pharmacologic and therapeutic management plans. You're getting the point, right? Provide supervision or consultation for other healthcare professionals. Manage the emergency department flow to optimize patient care. Things we see our trainees do every single day. And we can actually assess them on these things. These are the things that patients care about. These are the things our learners care about being incredibly competent at doing by the time they go out into practice. These are the same things faculty are doing every single day that we care about them being continually competent at and providing data on. And it's very straightforward. We actually ask our faculty, how involved did you need to be? Did you have to do it? Did you help a lot? Did you help a little? And then for emergency medicine, we're never not there, right? I needed to be there, but I didn't help. Or I didn't need to be there at all. As Mike Gisandi said, I could have been the third IV pole and it wouldn't have mattered. This is the way we think about this, right? And you make these decisions already subconsciously on shift. The way we're enacting this is really just saying, here are the things that you care about. I'm asking you to tell the resident actually how involved you needed to be. And then for all of you who are like, but the milestones. Each EPA encompasses a bunch of domains of competence, which all tie to the milestones. So when you think about, lead the resuscitation of a critically ill or injured patient, it maps to a bunch of milestones, right? A bunch of domains of competence. You need patient care, you need medical knowledge, you need communication skills, systems-based practice in order to do that. If someone is struggling with leading the resuscitation, then you're going to break it down into the milestones, right? All of these mapped milestones, you're going to think, okay, where is this resident struggling? Or for a faculty member, where is this faculty member struggling? How do we help them continue to grow and develop along that trajectory we care about? Okay. Now, a word about assessment. So I talked about programmatic assessment, all of these different dots. And people think entrustment is this really weighty concept. I want to come to this understanding that programmatic assessment is all of these different things. Say you bring it all together. You're doing all of this direct observation using the supervision scale, multi-source feedback from patient perspective, simulation, you're pulling data from your EHR. All of this is going to help with all of the dots to create this picture of competence for your trainees, for your faculty. You're using all of this data. And it's designed to give these inputs in this picture for you to, again, help with growth and development. But this isn't necessarily for your frontline faculty. And I think this is where people get really nervous because they hear the word entrustment and they're like, oof, gut check, right? I'm entrusting someone with my license. I'm entrusting them to do things. I'm going to give you an analogy. Who here has taught somebody how to drive a car? Hands, a lot of you. Great, okay. What you're asking your faculty to do every day is teach your trainees how to drive a car, right? You are supervising them the same way you would someone learning how to drive a car. So say today, on a nice sunny Phoenix day, you would let someone who you've worked with maybe once or twice drive on a nice side street in the sun, no big deal. Or maybe you'd let them drive on the highway. You're like, I'm really comfortable with this person. I would let them drive on the highway in this situation. I think we're doing great. But say all of a sudden you have this crazy dust up of a thunderstorm, and you're like, oof, maybe I wouldn't let you drive on the highway right now. It is the same thing in the clinical environment when you're working with someone. Perhaps you would let them intubate, a more straightforward patient, but then you have someone you're like, this is really tenuous, this is gonna be a really difficult intubation. I've worked with you one time, maybe, I don't know anything about you, I've just met you. Or perhaps that day you're just really hungry and you're less trusting, I don't know. And you're like, maybe not in this situation, or maybe I'm gonna let you lead the resuscitation of this patient because they're, again, a little bit more straightforward, and this one's a little bit more complex. It is okay for those things to happen because you are gonna capture that in those assessments. And each individual dot in and of itself is not a decision for that learner that they're going to, end all be all, ruin their career or hold them back or any of these things. That's not your job as an individual faculty member. Your job is to say, here's where we were, here's what happened today, here's what I think you can work on for your next shift, here's how I'm gonna coach you to be better. And that may change day to day, may change patient to patient. That is all okay. It is not your job to be the one who's making the decisions. That's why summative entrustment, this is the part that actually really is kind of the gut check, is made in your group decision process, right? Your competency committee, they get together, they look at all of the data, and they say, here's the keys to the Porsche. Good luck, Godspeed. Based on all of the data we have, I am comfortable with you leveling up. I am comfortable with you, going on and taking care of my family. That's where the decision comes from, and it comes from having this aggregated amount of data to make a sound group decision. And you're sitting here thinking, okay, Holly, this all sounds good. How do we do this? How do we operationalize this? You have kind of these bits and pieces of things that I feel like I can do at an individual level to help my residents grow and develop, perhaps to even think about how to approach this with my faculty, at least on the front lines. I would argue that precision education is what gets us there. Because competency-based education in and of itself is a really great model, but there has to be a way to operationalize this. So we talked about that shared mental model of outcomes and kind of this idea of learning curves, right? They don't have to be a straight line, it doesn't have to be this great upward trajectory. If any of us actually had that, that would be amazing. But most of us have kind of these fits and starts of how we get to the end point. Competence or entrustment committees to render those summative decisions, frequent judgments of transition readiness, and there should be feedback around that development from that committee to your learners about how they're doing and what they can do next. Those decisions shouldn't be made in isolation in a black box. They should be given back to your learners. But here's the part that's important. Once you give that data back to your learners and you say, here's what I'm seeing, there needs to be individualized learning that happens because they're not all the same. They're each going to need something different to work on, and there needs to be coaching to help them achieve that. So here's where precision education comes in. And this term you've heard a lot, right? I will say that I have a couple of good friends who have broken this into a really nice model. And precision education really means here's what your trainees, here's their assessment data, here are the gaps that they have, here are the goals that they have, trying to connect those things. Here are the analytics of that data, multiple different ways. And here are the interventions we would recommend from a coaching and individualized learning perspective. And then here are this cascade of outcomes, educational, professional, clinical, and then from a systems perspective. They're iterative, they're developmental. It tries to connect all of these things. And this is a great model, right? Everyone loves a good wheel, especially in education. I'm going to make this a little bit more actionable. And I know a lot of people in this room have read this book, and I'm surprised no one groaned as soon as I put this slide up. Everyone's like, oh, business book. I'm not a business book reader, but I have read this book multiple times. I actually think this is a really great model for how you get from point A to point B with competency-based education, because I think the flywheel model is actually how precision education helps you actualize competency-based education. Stick with me here. So a lot of people have seen this, and I'm going to kind of rebrand this for our context. So level 5 leadership, everybody here remembers that from this book, Good to Great. There's 2 core components, right? There's vision, and then there's humility. And I would argue when you're thinking about competency-based education and trying to connect it to precision education, there needs to be vision, yes. I think we've all kind of bought into that to some extent at least. But there also needs to be humility. We don't know everything. I would argue that co-production, meaning partnering with your learners, whoever they may be, students, residents, faculty, on getting to the outcomes that you care about is imperative. And that takes humility, particularly in leadership. We're not going to perseverate here, but I think that's an important place to start. Then first who, then what? So this looks familiar, right? This is competency-based education. It's about the patients and the learners and the outcomes that we care about for both of them and getting them to those outcomes. Makes sense. Now, you have to think about gaps and all of these other things, but I want to talk about this idea of a hedgehog concept, and somehow I found a way to put a cute animal in this presentation. So this is what the book talks about. It's basically what can you do to make money, what are you deeply passionate about, what can you be the best in the world at. We're rebranding this. There's a precision hedgehog concept. And what that means is an overlap of the personalized data we can provide, this gets to that assessment piece, what patients need, outcomes, and maximizing learner potential, that growth and development, the coaching, the individualized learning, brings it all together. So precision hedgehog concept is this overlap. We're going to dive into this a little bit when we do some examples. And then thinking about the data. Data not just about our residents and their assessment or our faculty and their assessment at different phases, but the gaps and identifying those gaps and filling them appropriately using data. And then developing a culture of coaching and feedback. Again, this comes back to this idea of co-production and thinking about precisely what it is our learners need and how we meet them there. And then finally, redeploying resources. We spend a lot of time on developing content, when in reality, we probably need to spend a lot more time thinking about how to deploy our resources towards individualized learning and coaching people to maximize their potential and meet those outcomes we care about. All right, and those outcomes, again, need to be kind of iterative, developmental, and thought about on multiple levels. So, I may or may not have redone this wheel. So we have level 5 leadership, patients, learners, toward outcomes, trainee context and data, including gaps, our precision hedgehog concept, the culture of feedback and coaching, and then redeploying our resources towards outcomes. The whole point of this is that you take all of this and you take your competency-based education cake, and if you spin it through this cycle, you're going to be able to actually operationalize competency-based education in a way that is meaningful. And I'm going to give you 3 examples before I wrap up. First is the obvious one. So we talk a lot about assessment. What does it look like in this model? So humility and leadership, co-production with learners on what assessment can and should be. What is it that they need? What can we give them? It has to involve patient and learner-centered outcomes, and it has to be done in a psychologically safe and optimized learning environment. The data that you gather should be optimized, should help optimize learner growth to meet patient needs. Really, this is the crux. But you do that in a culture of feedback and coaching and by reallocating time and resources to optimize patient and learner outcomes. it all comes together, right? If you operationalize it like this, that's what helps you actually take your assessment, make it competency-based, and operationalize it in the clinical environment. Now, you're like, where is all the papers in this talk? Nobody thought that. But precision education, nobody thought that. We are going to talk a little bit about papers that you can go read after this that I find particularly provocative. A good friend of mine, Javid Sakura, wrote this paper about precision education and equity. And we've talked a little bit about co-production. But what he posits here is that in order to achieve equity in assessment, because this is a big thing we talk about, is equity and bias, you need to have that co-production model with your learners, but it has to be a diverse group of learners, and you have to have transparency around your outcomes, your data, what you're gathering, and how, and iteratively audit that assessment data. I don't want to leave this out because I think this is actually a really important part of assessment for competency-based education. All right, now, more examples. Initial certification. Thought I left faculty out. I did not. So humility and leadership. This is really thinking about co-production between the board, between faculty, between residents, between program directors, and having that vision and that humility to come together around what are the outcomes, what are we doing here, how do we get people to where they need to be. Again, it needs to be patient and learner-centered, the outcomes. The assessments need to align with those outcomes. And then providing relevant patient-centered data for improvement. I think that's something that we haven't necessarily thought a lot about, but I'm going to bring a paper in that talks a little bit about that. But how do we actually help connect patient outcomes to our initial and continued certification process so that we know that we're meeting the needs of our patients? Having feedback and coaching as part of the process, which I know that there's already been a lot of thought on that. And then aligning resources across training, so graduate medical education, and practice to really include certification longitudinally in that thought process. Some other good friends of mine have thought a little bit about this and thinking, how do we connect patient measures to our assessment practices, particularly in graduate medical education, but also for faculty, and thinking about continued certification. And they do these things called resident-sensitive quality measures, which really tell you how you're doing and your patient outcomes. And some of these have been in pediatric emergency medicine tied to asthma care. Others have been in internal medicine tied to diabetes care. Thinking about how we can actually connect what matters to patients to what we're doing in the certification space is kind of a provocative thought process. And then finally, my favorite topic right now, this pie-in-the-sky idea of how do we actually optimize high-performing teams when we think about health system science. Now, this requires a fair bit of humility within leadership, but also within the system. A fair bit of vision, but also humility. And then analyzing the environment to really determine what is it that the patients and the learners need, particularly in a team setting. Giving psychological safety so that there can be practice within that setting. And then providing real-time data regarding how that team is functioning and how the patient is, what the patient is experiencing. And then having this culture of feedback and coaching. Again, you have a psychologically safe environment in which you're practicing, so you can have feedback and coaching. And time and resources are focused on CQI of high-performing teams to meet those outcomes. Now, the reason I say this is kind of a pie-in-the-sky example is think about sports. Think about how much data you get as an athlete. So I love baseball, so Christian Yelich from the Milwaukee Brewers goes up there, takes a swing, has a single, whatever, comes around to score, goes back to the bench, someone hands him an iPad, right? Every athlete you see this happen. They get handed an iPad. They can look at the stats for dozens of things when they go up there and have an at-bat or their fielding stats. The launch angle, the velocity, the bat speed, what the pitch was, what the angle of the pitch was, ballpark stats. We have already some of the capacity to provide some of this information for our teams in environments where they're doing resuscitations, in the OR. This is actually not as far-fetched as we might think it is. You can walk out of a resuscitation and someone can hand you an iPad as your team and think, okay, how did I do individually? How did we function as a team? How can we be better for next time? That's how competency-based education and precision education come together. And really, this is all towards adaptive expertise, right? Because when we encounter something in the clinical environment we are unsure about, and this happens all the time, What really makes it so we can trust people to take care of our family is that they know when to take a step back, reframe the problem, learn, grow, develop, and do their best by their patients. So hopefully I've given you a lot to think about. But again, I want to bring this back to it's about patients and the outcomes they need and what they care about, and our learners, those are my interns, and making sure when they graduate, we trust every single one of them to take care of our families. In any situation, including the craziest, because these are our future colleagues, these are our future co-faculty, the people who will take care of you when you are sick, and someday you may wake up in a hallway bed in the emergency department and look up and see someone you trained. And you want to make sure that they are able to take care of you. And with that, I will take questions.
Thanks for doing this work and for a really great presentation. I'm Sean Michael from University of Colorado and from CMS. This is really a question from CMS. I'm the good guy CMS, though, don't worry. The fundamental underpinning of how we've paid for particularly graduate medical education in this country is time-based, right? And so I'm curious what advice you would give to the GME funders, and CMS pays for the majority of GME in the country, but not the exclusive funder, right? But what would you say to GME funders sort of globally around how they should be thinking now to sort of lay the foundation for true CBME over the future and move away from sort of the time-based assumptions that are baked into medical education for many, many years?
It's an excellent question. So I think there's a layered way to think about this, right? I don't know that we are ready to say immediately we're going to time variable, right? I think we need to get those 5 core components down really well, get this precision education piece really operationalized. There are models out there that have been employed. I'm thinking specifically about Harvard Pathology, where they have this promotion in place model, where they basically say, you're ready to go, but we are in this funding model. We're going to keep you here and let you function as an attending. That's actually more a question for hospital credentialing and board certification, and how we say this can happen earlier. And you really need both to be on board to make that happen, which is kind of difficult in a lot of specialties, which is why they've only been able to do it in one. But I think a promotion in place model really kind of helps to ease this transition. But when you think about GME funding, the places that are able to do this, keep people longer, perhaps do this promotion in place model, tend to be the ones that are over cap, right? And that is the programs that have the funding outside of CMS, and not all programs have that. So when you give the opportunity to think about how does CMS fund graduate medical education, the way I would think about this is I think you're going to have it as a pooled fund across not individual residents, but across a program, right? Because you're going to have some people leave a little early, some people stay a little longer, and I would probably think about funding it by program, not individual. I think a lot of people think people will leave years early. That's not going to happen. It'll be a 3-ish month buffer on either end, probably. Yes.
Hi, Brian Pedigo, Residency Director, Harvard UCLA Medical Center. Thanks so much. Awesome talk, and something I struggle with as a program director in terms of, I think our model for education has been just take really smart people, have them diffuse across 3 or 4 years in a high acuity environment, and hope they come out okay on the other side. So yeah, I absolutely love this, and I guess I'm wondering, one of the challenges is you need to get that data, and you need to get that data from faculty, right? And many of us are in systems like you have MedHub, and it's an absolute disaster to try to get someone to log in and actually get that data. So how do you actually get the data from those faculty in a way that's a low enough barrier where it actually happens, or we actually then can go into our CCC and not just have groupthink and actually use a data-driven approach to make entrustment decisions?
I feel like I should have someone from our grant team get up and give this testimonial, but so we have partnered with a quality improvement collaborative out of the University of Michigan as part of our grant, basically to say we have this data collection tool where you basically go in and say, here's the EPA, here's how much I needed to be involved, here's what you did well today, here's what you should work on for next time, done. Like, that's our frontline assessment. You can do that using a fancy app, which is going to eventually be available to all of emergency medicine residency programs, hopefully in like a couple years. Or you can even do it using like Qualtrics, RedCap, something that's much more approachable to your faculty. We started using Qualtrics and QR codes. But you and I can talk offline about that later. Hello.
Hi. Thank you for this wonderful talk. You hooked me in humility, and I have a couple of reflections and questions about the structural limitations of CBME. So if assessment, for example, is this combination of, or this movement from measurement to entrustment to a system, and we have self-eval and workplace assessment and independent assessment, there are some structural limitations, and I do wonder if we underrepresent those structural limitations and overrepresent sort of the knowledge areas, similar to climate change and racism, all that. There's structural elements that far exceed the knowledge about them. So as an example, you mentioned 40–60% of program directors that have graduated someone that wouldn't take a family member. Another number would be what percentage of residents have graduated that they wouldn't take care of patients. And how many of them, is it the residency director's decision? Or is it HR's decision or a lawyer's decisions and all that? And so if you're a program director that's 10 years in practice and there's one or two that you could do, it's still 1% to 2% of graduates that don't go there. The whole time versus accountancy-based thing, it actually handcuffs us as former program directors of the structural pressure to graduate someone on time is incredible. And then ultimately the humility, the whole structure of medical education is taught from faculty that have to demonstrate a regional, national, international reputation and express that on a basis. So our focus is really on confidence, and we worry about imposter syndrome as something to avoid, rather than calling humility syndrome as something to grow with. But ultimately, I'd love your thoughts on some of the structural issues. I know you're aware of the Canadian system as they rolled it out, on how that will help us, inform us for the future. Thank you.
Yeah, absolutely. So I think the Canadian system will help us from a pitfalls perspective, certainly. But I also think that there are unique challenges in our environment that the Canadians didn't necessarily experience. But I think this goes to implementation science, and I would challenge the operations and QI folks in the room to partner with your education teams on thinking about this. Because when you think about implementation science, it really challenges us to think about what are those barriers, particularly from a systems and organizational perspective, and how do we address those? Because exactly to your point, if I, as a residency program director, think like, okay, I wouldn't graduate this person, and I have all of this data, particularly in this system, that tells me that I shouldn't do this, but I have an office of the general counsel that says, well, you absolutely have to do this because we don't want to end up in litigation, that is a systems level barrier. And that is something that we need to think about. It's not just education that needs to be having this conversation. We need to speak the language of everyone in our environments, and that includes the C-suite of the hospital, the GME office, general counsel, our systems managers, thinking about how this actually operationalizes fully in a complex healthcare system environment, but also a complex educational environment. Because even the preponderance of data doesn't necessarily always mean we do the right thing. All right.
Excellent talk. Thank you, Dr. Caretta-Weyer.